This first of all, we are going to discuss constipation guidelines. All right. Okay. Tell me, what is your concept about constipation? Some will tell me like there is a charting system, this and this. This is the number of the stools. This is the consistency of the stool. No, for these guidelines they are basically to manage your patients. Okay, whenever they will basically this is the, when we come across our patients, what scenarios do we see? Okay, whenever they talk about the constipation, we always come across few terms, right? One is constipation, one is fecal swelling, one is encopresis, one is fecal incontinence, and one is fecal infection. Oh my God, what is this? Why they are talking? The thing is, like all the things they are saying, the patient is not passing stool properly. Okay, what is the proper passage of the stool? They are saying that may be constipation, that may be fecal swelling. Okay, what is the difference between the two and between all these terms? Any idea? Anyone who want to tell me about this? What is the difference between all these? Any idea about this? Okay, so let us discuss. What is the definition of the constipation? See, this is intestine. Okay, what is the constipation? It is not like that we have read before. There is difficulty in passage and difficulty in washing the your flesh and other things. No, this is the intestine of the patient. All right, and this is the fecal matter. What is constipation? This constipation is the difficult passage of this hard stool. Difficult passage of this hard stool, and that is for more than 1 month. It may be for 1 month or more than 1 month. So here they have decided what is the duration. It's not 2 to 3 times per week or 1 or 2 times per day. No. They say whenever any patient he or she feels difficulty in passing the stool and that lasts for 1 month or more than 1 month, this is a state of constipation. All right. The next thing they are talking about the fecal swelling. What is that? That is also a form of the constipation. But see, whenever like this is what is the way how we pass through. What is the reflex? There's definitely a coordination between the contraction of the muscles of the intestine, between your brain, and between your environment. This environment that is very important. If there is any defect in the environment, the child is feeling difficulty. That may also cause some difficulty in passing stool. Okay. Whenever the child is not aware, but he is having some problem in the brain, in the spinal cord, all right, like that may be a case of your nerves which are coming to these muscles of the small intestine and which are causing contraction. Whenever there is any problem in the nerves which are supplying the muscles, then this patient may have constipation or some improper passage of the stool. So one thing I was talking about, that is the environment. One thing is defect in the brain, in the spinal cord problems. Okay, and the one thing is that the eating habits of the patient, they are not well, and they are causing the stasis of the stool. And another thing, the child is not going to toilet properly. Okay, so now we will see what is the fecal swelling. Fecal swelling, you see this way. This is the intestine, all right, and this is a fecal infection, hard stool that is going to stay here in the intestine of the child. Okay, what is the fecal swelling? Due to this obstruction, the loose stool. This is a loose form of the stool. It is having overflow. All right, this is having overflow from the intestine of the child, and this is known as the fecal swelling. Here, what is the problem? Stool is not normal. It is abnormal stool, hard stool, but the stool that is being passed out, that is low stool. So the what is the main reason here? This fecal infection is the reason here. Okay. What is the behavior of the child? In this case, child is not having any sensation of the passage of this loose motion. That is known as a fecal swelling. They say there is passage of the loose and offensive stool in child's underwear over which child has no control. So it means here the behavior of the child was normal. Child is not having any control over here. Due to this fecal infection, there was passage of the loose stool from this side. Okay, so in this case, there is abnormal stool, but the behavior of the child is normal. That is known as the fecal swelling. Why I am telling you all this thing, I will tell you because that is very important for the management of the patient. The third thing is encopresis. The third thing is encopresis. Okay, what is that? Voice is not clear? My voice is clear? My voice is clear? Can you listen me? Can you listen me? Okay. So, Divya, I was talking about the forms of the like the terms, the different terms we come across while talking about the constipation. One is the constipation. They have fixed the duration and the consistency, and the next one is the fecal swelling, where the child is not well aware of the passage of the loose stool, and the third one is the encopresis. Okay, what is encopresis? See here, this is the intestine. This is a fecal matter, okay? But see here in the encopresis, the child is passing normal stool, all right? That is the normal stool, but it is being passed by the child at the abnormal place, at the abnormal side. It means child is well aware of that he or she is passing stool and it is not the proper place to pass the stool. So what is the problem basically here? There is a problem in the environment. The child is feeling insecure. The child is not behaving well. Here the stool that is of normal consistency. When we talk about this fecal swelling, the stool is of hard consistency. It is abnormal, but the behavior of the child is normal. In encopresis, stool is of normal consistency, but the behavior of the child that is abnormal, and the place of passage of the stool that is also abnormal. These two forms you basically have to differentiate whenever we come across the exam questions. They usually give these two options where we have to choose. Okay, how will you manage this case? What is the basic management? The child behavior is normal, but the stool here basically the problem is what? There is fecal infection. So when we give laxative to this child, his fecal swelling will be improved. Alright, the parents, the mother will say, Doctor, my patient, my child is passing low stool and you are adding laxative to my child. You will tell, this is the cause. This is the cause of passage of low stool in your child. So this is the treatment. When we will give laxative, this fecal infection will be gone and the passage of the abnormal stool will be like this fecal swelling will be solved. Okay. Here the stool is normal, but the behavior of the child is abnormal. What would be the management here? What would be the management here? Who will tell me? Here you have to send the patient to the child and adolescent mental health services. Why? Why we are not giving laxative? We say this is behavior therapy. Basically, we will send the patient, refer the patient to CAMH. Why? Because stool is of normal consistency. Okay? Yes, you will get recording of this session. Okay, all right. So this is the basic difference between the two. Next comes the fecal incontinence. Now the same thing, but what is the difference between this fecal incontinence and the fecal swelling? Okay, fecal incontinence. See here, when I was talking about the fecal swelling, see here, I said there is overflow of the feces when I said this is the fecal swelling, I told you like this is the hard stool which is present in this intestine, and there is overflow of the loose stool from that side. What happens in fecal incontinence? See here, there is some anatomical problem. All right, there is overflow of the loose stool, but here was the problem with the fecal infection, but here is some anatomical or organic layer. What is anatomical problem? That may be some obstruction, like you may have stenosis and other volvulus or other things. And what is the organic problem here? That may be your neuropathies. The intestine, the neural crest cells, the sympathetic or parasympathetic cells to this mesenteric or something like that was mesenteric plexus. They are not behaving well. They may cause organic obstruction to this large intestine, and there will be overflow of the stool from the intestine. This is known as fecal incontinence. Okay, fecal infection. That's yes, feces was impacted, and when it is chronically impacted, it is not disinfected by you, maybe by laxative, maybe by manual disinfection. It will cause the dilatation of the large intestine. In this case, we will see that this is a case of a fecal infection. Okay, but remember, all these causes, all these forms of the constipation, the most common is one, that is idiopathic functional constipation. If we have 100% cases of the constipation, 95% will be of the functional constipation. The child is playing, he or she doesn't want to go to the toilet. He doesn't want to quit the play our games of that is why it causes fecal infection, and which may appear in the form of constipation and all other problems. Why I am telling this is because whenever you read a scenario of the constipation, you must have a deep concentration which type of constipation or terms they are talking about, and if it is a functional constipation, what in what way we have to manage this patient. Okay, they say the most common causes they are basically functional, but you have to see the red flags. Okay, a neonate who didn't pass the meconium in the first 48 hours of their life, definitely this is not a case of functional constipation. Okay, a CP child who is having neuropathic problems, who is having some derangement of his in his upper motor neurons, maybe some problem in the intestine, your spinal cord, that is definitely not a case of idiopathic your functional constipation. So you have to remember the red flags. All right, where you will see, is it a child who is having some neuronal problem? All right, what was the time of the passage of the first meconium? Whenever there is delay in the first meconium passage, we have two differential diagnoses. One diagnosis that is about the Hirschsprung disease, and what about the second one? What is the second one? What we have in the delayed passage of the meconium? The first one is like your Hirschsprung, and the second one is your cystic fibrosis. All right, very good. So these 2 points, these you have to consider like that may be a case of this disease. Okay. Now they say these are the red flags. I will read it very quickly. Neuropathic wall. We all know, right? Any problem in the intestine, your upper motor neuron, or your lower extremities, like your spinal cord problems, you should consider the cause of the constipation. That is this one. Next is a Hirschsprung disease. There is delayed passage of the meconium, just all signs of the abdominal distension and other things. Next is the anteriorly displaced anus. That is very important. They say you have in the examination. When I was saying about this may be a case of neuropathic bladder, I have to look for the either bladder is palpable or not. What are the reflexes? The main thing, the very first thing, you should look for the anorectal abnormalities. They are basically much associated with your upper motor neuron, upper motor and lower motor neuron problems. But you should see what is the position of the anus. Is it at its normal place? Is it anteriorly placed? And what is the tone of this anus? Alright. Is the speculus are normal? Basically, when it is having some problem, it is also due to your sympathetic and parasympathetic innervation problems. That may be any neurocristopathy which is causing problem here. There may be anal stenosis. The child's anus is not open. There is imperforation. That is why he's not passing the stool. The most common we usually come across, that is the change in the milk. The baby was previously taking mother feed. Now the child has been shifted to some formula feed or cow's milk. That may also be a cause of the constipation. Basically, the intestine has some change in the like the motility of the muscles and contraction of the muscles whenever there is change in the dietary constituents of the food. All right. So these points we have to see. See here, this is a red flag. What is this? Delayed cow's milk protein allergy in the first year of the life. This is a red flag. We usually see like cow's milk protein allergy that is going to present in the early life in the form of what? In the form of severe abdominal colic. But yes, it may present in the form of constipation. In the first three, it's not in the first 3 months of the life. It's not in the first year of the life. Within first 3 years of the life, that may present like this. Okay, one endocrine problem. Okay, if we look at the endocrine problem, they are not present in your red flags. Thyroid disease that may cause constipation, but if we talk about our red flags, the organic constipation causes, no, that is not present here. What is the reason behind this? This is because they see here red flags are the sign where you have to emergency manage the patient that are usually associated with your organic see here organic constipation. All right. When if we consider thyroid as the major cause of the constipation, no. The thyroid that is basically for your brain development. That should be concerned with your brain, not with your constipation. That is a secondary associated factor which may be present with this one, but yes, it's usually not the presenting complaint in case of thyroid problems. So if we talk about the red flag signs, we see here there is no endocrine problems. They are just talking about the intestine. They are just talking about the intestine and just talking about the innervation of the intestine, that is by the nerves. All right. So differential diagnosis, they have talked about the organic causes, like which are all they have discussed in the red flags. Next, the causes may be your endocrine problems or metabolic problems. There is hypothyroidism, hypercalcemia, that may be in case of hyperparathyroidism, your hypokalemia and cystic fibrosis. Okay, what are the causes of hypokalemia? Multiple types. We will discuss that later on. Okay, constipation that is induced by the drugs. In some question, they will give you the child is on the palliative care. He is well controlled on the morphine, on the opiates, but now the child is having constipation. Will you treat this child with antidote for the opiates? No. I will tell you there are different way of the management. The child pain is well controlled on this much amount of the opiate, so I will not decrease, I will not give antidote of that opioid in that palliative cases management. Celiac disease usually present with like a diarrhea, but yes, it may present with your constipation. Okay. Investigation, we all know we usually do investigation according to the clinical presentation. Definitely. If the child, I'm suspecting this is a short and obese child who is having coarse, dry skin and he's some developmental delayed. If thyroid is my first differential diagnosis, definitely I will not go for the rectal biopsy first in that case. So investigation will be different for the different clinical presentations. All right. Now see, like if should I go for abdominal X-rays? You are going to confirm constipation on your X-rays? No, they say not usually required, except for the cases where history is suspicious. But clinical examination, that is difficult. The child is very obese. He is having severe constipation. Mother is telling us. In that cases, we may go, but yes, this is not the main diagnostic investigation of choice in cases of constipation. Okay, this one is important. All right. When you have to go for the rectal biopsy, we will go for the rectal biopsy in case of what? That is Hirschsprung disease, where what we may say to look for the neuropathies and others biopsy findings. They say whenever you have history that is suggestive of your Hirschsprung disease, like delayed passage of the meconium, all right, constipation since the neonatal period, definitely the most common cause in that case is this one. History of the abdominal distension and vomiting. History of abdominal distension and vomiting along with these features. A child, a neonate comes to me with abdominal distension and vomiting. I will not straightforward go to the rectal biopsy. If the history suggesting like the child is having delayed passage of the meconium, yes, then I will definitely consider the rectal biopsy. Failure to thrive for faltering growth along with these features. Family history of the Hirschsprung disease along with these features, then I will go for the rectal biopsy. Okay. Now they will talk about the management of the constipation. Whenever we talk about the management of the constipation in the exam, they will give you scenario like fecal swelling, encopresis, organic causes, and other causes. So we have to manage the patients according to the clinical view of the presentation. They say what are the principles of the treatment? Definitely education, diet and lifestyle, all right. Increased water intake, increased fiber intake, and increased exercise, increased mobility, decrease the watch time, screen time. Behavior management, this is not the behavior management of the child only, all right. The behavior management is basically of the parents and the family. It starts from the parents and the family, then it will move towards the child. Okay, that is the behavior management. Okay, definitely I'm not going to manage the behavior of a CP child who is definitely having a problem. This is basically in that cases where the passage of the stool is normal but the site at the place is abnormal. This is required for this one, and family and the child and the parents all are involved in the behavior management. Supporting the child and the family. This is very important by a mother. I guess we all are mothers and we can feel if the child is having encopresis, if the child is having fecal swelling, what happens to the mother? So these mothers definitely need more support as compared to the other mothers. All right. This is very important point. You are going to definitely change the behavior of the parents and the mothers, but you should support the child and the whole family too. Okay, education, give parents clear explanation of the pathophysiology of the constipation and swelling. Okay, after reading this one, I would like you must know what is the difference between constipation and swelling and encopresis. That is all what is required practically and for your exam point of view. Okay, diet and lifestyle management. Yes, laxative along with laxative ensure adequate food intake, high fiber diet, and physical activities. Behavior management we will do that where we feel like normal passage of the stool at the abnormal places. All right. So what are those? Use behavior management in combination. Regular toileting, unhurried time on toilet after meals, correct toilet position, maintain diaries of the stool frequency, regular review and positive reinforcement. Okay. Never ever give punishment to the child for this behavior and others. Discourage negative response to the swelling from the family. Yes, this is basically required. May need counseling or psychological referral in case of motivational or behavioral problems. Okay. So next is the medication disinfection in the presence of the impacted stool. So first we talk about the behavior therapy that is for the mother, for the family, and for the children. And next one is the medication. See here, this medication, which medication is basically used. Okay, just 1 minute. This infection, this is the intestine. This is disinfected. How I'm going to disinfect it? First one, always use, yeah, that is Movicol sachet. Number one, Movicol. Number two, I would say Movicol. Number three, I will say Movicol. It means you should learn the importance of using this Movicol sachet in a patient who is on palliative care, who is having this impacted stool. You should use this. You will not decrease the dose of the opioid. You will not give the antidote of the opioid for the disinfection. This is a CP child who is having infection. We will use definitely. Okay. This is a case of cystic fibrosis where the child is having ileo and cecal infection of the stool due to loss of the colloid and sodium and water from this stool consistency. Here we will disinfect it even it is present in the ileocecal region. There is a very high region from if we talk about like anus and all parts of the last part of the rectum. My first choice should be the Movicol sachet. Okay, how I'm going to give this? I'm making a table of day 1, day 2, 3 and 7. Okay, see the age of the child. More than 1 year, less than 1 year. Less than 1 year, I can give one or one a half or one sachet, and more than 1 year, this is the number of the sachets you may use. One sachet in the morning, one sachet in the evening. Not past the stool, two sachets in the morning, two in the evening. The child has not passed the stool, I will give another two sachet in the morning, two in the evening. Not stool is not passed, I will increase from 4 in the morning to the 4 in the evening. Okay, I will decide how the okay. I will make a table for these 7 days. In these 7 days, the mother will decide what is the maximum amount, what is the maximum number of the sachets which has caused my baby to pass the stool very softly, very normally, without difficulty. Suppose it has the 8 sachets per day, like maybe 8 sachets with the 8 sachets per day, my baby is able to pass the stool. What I will do, I will make my child to use this sachet for 4 to 6 months. At what dose? At the half of the dose of the sachets which were used, which were basically required for the passage of the normal stool. Like I will give this child 4 sachets per day for the next 4 months, 4 to 6 months. This is the maintenance dose. This maintenance dose will make the habit of the intestine of my child to contract at proper times. All right. So this is the basically therapy for the constipation. Movicol sachet. Usually in the exam, they do not ask you about what is the amount and how you are going to maintain. This is just for I am giving you a little bit concept of that, but basically that is Movicol, 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 Movicol. All right. If the child is not passing stool after using this much amount of the Movicol, then what we will do? We will add laxatives like Sina or sodium picosulfate. All right. If no results with this one again. Okay. Here they have given this 1 week table how you will prescribe this to the patients. Okay, rectal disinfection. See here, if we talk about the cystic fibrosis, after that we will read the guidance for the cystic fibrosis. Like the patient comes to me with the distal intestinal obstruction, he is having constipation. Okay, I would like to disinfect it with oral medication. Number one choice, oral medication. Number two choice, oral medication. Number three choice, oral medication. This this is paid. This is paid. and I will go to proper. Screen is proper. Okay, that was clear. All right. Okay. So they say your first aim should be disinfection by the. You may use this one sachet not effective, the second one and the third one. If all this fail, then you should go for the rectal disinfection. Why this is so? This is because they say you should use sodium citrate microenemas. Please do not try to use phosphate enemas. I will show you a literature where they have told us about the toxicity and the side effects of the phosphate enemas. If you have to use the enemas, you will go for the sodium citrate, but definitely you should try your maximum not to go to the phosphate enemas. This is from the NIH article. Published in 2022. Okay, here. Conclusion of this study was that phosphate enemas are potentially toxic, particularly in young children with Hirschsprung disease or any disease that is causing definitely constipation or obstruction, and in the elderly with comorbidities. Raised awareness of the risk of the phosphate enema is still required. Ideally, we should not use that. And what are the side they have told here? That was about the kidney failure, heart failure, kidney and electrolyte disturbances. These three discrepancies they I have mentioned with the phosphate enemas, and they say you should try not to use these enemas, especially in the children. So, same thing they have written here. If you have to use, you should not use. If you have to use, you should go for the sodium citrate enemas. Please do not go to the phosphate enemas. If you have to go, use only under specialist supervision. Consider sedation if the child is distressed. Okay. All this Meyer fails. What the mothers do? Manual eviction. Basically, I just to memorize. Like if all Meyers fail, then the surgeons the general after using general anesthesia, consult with the pediatric gastroenterologist or pediatric surgeons. Okay. The one thing when you read these guidelines, please always look what is the multidisciplinary approach, which department involved in this special case. Okay. See here, that is the gastroenterologist and the surgeon which are going to involve in these cases. We may go for the